this. My teaching style is all over the place, and I try to bring in a lot of background to kind of give you some perspective on where this stuff applies. This is my least favorite chapter, okay? So I'm going to go ahead and tell that. So when you look at this and you go, he has no idea what he's talking about, understand that this is not my strongest suit. Basically all the how things came to be. So I'm not going to lie, okay? I'm just telling you up front. The second piece of this is I like a lot of feedback because then it tells me you get it, and then I don't have to spend time reading a bunch of slides to you, okay? So if you give me feedback, I say, okay, they got it, we can move on. I don't have to worry about spending a lot of time on this. That makes sense? Is that easy enough for you? The heads are nodding, but I'll take that as feedback. Okay. Well, this is going to be the evolution, right? And I'm not going to spend a lot of time going through these objectives. You get it, right? You know what your objectives are. You know what we're trying to do here. We're going to talk about the history of healthcare in the U.S., where we came from, why we're in the mess we're in, and see what other attributes it has. Okay, so when you think about American beliefs and values in healthcare, what are those? Let's see if this is working. Oh, it's working great. What are American beliefs and values about the U.S. healthcare system? So this is where I say this is a question, not a statement. What do you think about the U.S. healthcare system? Where do you think we came from? What made us what we are? What are we as Americans? Where did we come from? We came from where?
We're rebels.
Yeah, we're rebels, right? We came from a whole line of rebels. In fact, we can't even get along with each other because we're rebels, right? I mean, that's the essence of it, correct? You think about, all the founding fathers, what their belief was behind the whole American system. What was one of the main bases of leaving Great Britain? Autonomy, yeah, that's a huge part of it, right? And taxation, right? And you think about those two aspects, and you think about why we don't have a real system of healthcare, it applies completely, okay? Because of this, you think about where our programs failed to make inroads. We can't have a national health system. You think about where we are right now politically, and you think about, for example, and we'll dive into the Affordable Care Act a lot, just because it gives us a good summary of where we are as Americans. I mean, it was not passed with a broad consensus, was it? What kind of conditions would make things right for a national health care system in the United States? Did you guys watch that video last week that you swore you'd go home and watch? Everybody watched it? Okay, so what kind of conditions made that possible in those countries? They didn't start where we started, but what needs are there in our country to become prevalent in order for that to become a focus, you think? Everybody's super uncomfortable, like, I don't want to be the first one to speak. It's okay. Promise, there's nobody going to say you got the wrong answer on this.
Sorry, asking what were some of the things that were characteristics of the cultures, or
yeah, what did their culture dictate, and how can our culture become like their culture so that that's an acceptable thing? What is there? These are opinions, okay? There's nothing that you're gonna. That's why I said you can't be wrong.
One of them used social insurance.
Okay. And how does public opinion come around that? How do you get there?
I feel like a lot of them had better access to healthcare in general. I know that they would go to the doctor kind of less often in some countries, but they had a set scale of like payment systems, and I think that helped a lot with charging and people paying the right amount. If that makes any sense.
Yeah, it does makes a lot of sense. And so when you talk about charges and people paying a portion and whatever the correct amount towards those systems, you have to think about, go back to our initial comment about what our society is like. What are we willing to pay? What are we willing to do in order to get there? Do people see this as a social need versus an individual need? So you have to kind of play those two things out and see where we are, right? So when we think about the Affordable Care Act, you think about where we are now. So there was, when it passed, the big requirement was the individual mandate, right? And we're not going to go into great detail about the Oregon plan or the Massachusetts health plan, but those, especially the Massachusetts plan, had an individual mandate, and it dictated that everyone had to have insurance or face a penalty, right? And so when the federal judge, federal judge just stated at the end of 2018 that because they had struck down the idea of individual mandate, that the Affordable Care Act couldn't even stand. So that's pretty momentous, right? You have this big law on the books, and a key element of it is was taken away, and now because of that, they're saying that it's unconstitutional. Okay. And if you look at how the Affordable Care Act was passed, it was pretty interesting, and we'll jump into that a little bit more later. So what other items, so what's technology? Let's focus on that first. What is considered technology in our healthcare delivery system? Historically, what's the first thing that pops in your mind when you think of technology in healthcare?
Pretty big advancement, like a new surgical machine or technique.
Yeah, so surgical machines, techniques, machinery, right?
Yeah.
But you think about from the beginning of medical practice in the United States, something as simple as hand washing could have been considered technology. That's an amazing thing how far we've come, right? You think about information you can get on your phones. How many of you have a smartphone? Probably the better question is who in here doesn't have a smartphone, right? And you can access information. I can access my health information through my my insurance provider on my phone anytime I want. They give benefits for checking in on my, do a quarterly update, do my annual physical, put it in there. All this stuff gives me a rebate. I mean, it's great, right? This is good stuff. But back in the early 1700s, think about what was considered medical technology. All right. The view of practice in medicine. What is your view of medical practice? What was medical practice? Who was considered a physician? Now we look at this and we say, this is not such a, we know who our physicians are, right? But before, you go get your shave and a haircut, and then the same person would take care of your illness. Imagine that. You go get have some bleeding done because you're not feeling so well. Think about poor George Washington. Yeah, it's a rough place to be, right? So, what about how does managed care and the corporatizing of physician practices play a role in our current system? They're a huge part of it, right? They've become a key element. They have, think about some of the byproducts of having this huge structure in place. What are some of the advantages of this? Do you know? Do you think of any advantages of having, growing power within managed care?
Let's say for like state of Franklin healthcare, you can get referrals pretty easily across the board. If you wanted to see a physical therapist, or if you wanted to, go to walk
it's kind of like having buying power, isn't it? It makes access easier. What's the downside though? Think about our current, if you're familiar with the merger that occurred between that created the monster of Ballad. What's one of the big hangups? What are people's biggest fears about that? Monopoly. Yeah. Yeah. Well, what's the big disadvantage with a monopoly? What are some of the big disadvantages of a monopoly?
Nowhere, like you can only go to that place and they might have a high price, but you don't have any other options.
Yeah, pricing, the position availability. Right now, already they're seeing there's a lot of practices are finding out that they're only, for example, delivery of babies is only occurring in one location or two locations. So, and your practice may be limited as to where you can perform a procedure. So those make things difficult, right? Cost is obviously the biggest portion of that. And it creates a really high administrative level, doesn't it? Because now with these corporations and growing managed cares, you have to have administration in place to keep up with all of that, among other things, the other reasons for it. So here's just a quick slide on insurance itself and how a lot of things have come in, a lot of the changes that have occurred over the years in modern times. You think of, the change from ICD-9 to ICD-10. Are you guys familiar with that? So that required tremendous amounts of training just to change billing and coding. That's a lot of money involved in just implementing a new coding system. That was not much different from the previous version, but it added and took away some coding aspects that hadn't been there before. And so it made it very difficult for a lot of hospitals. Then you have using different electronic health records, the mandate that everyone go electronic had some financial incentives at first, and then they disappeared, and the requirement still remained, but yet not all electronic health records communicate with one another, right? So that advantage, that was supposed to be one of the bigger advantages, it disappeared. Because everybody wants their information to be proprietary. So we'll skip over the bulk of this because we'll dive in pretty deep here in a second. So think about medical practice. Think about medical procedures in the 1700s. How many of you can think of an example of a medical procedure in the 17 to 1800s? Did you have the use of X-ray and MRI, and the understanding of how to diagnose was not so great? Like I said, your barber, you might go to your barber for something. A lot of really primitive procedures, even just the idea of what do you call it? Quarantine was very limited. I think the first quarantine first idea of quarantine came around probably in the 600s, but it wasn't for the same reasons as we understand it now. So it's really changed a lot, right? The medical procedures. Can you imagine telling you have an abscess on a bone in your leg, and the only source of anesthesia that they give you is alcohol? That doesn't sound very fun, right? They go to saw your leg off, and you just have to take a hard shot of whiskey. Does that sound like your idea of fun? Yeah, now you take some propofol, and you sleep like a baby, and you wake up and like, what happened, right? So life's not so bad now. I had ankle surgery about 7 years ago, and started to come out of my anesthesia about 3/4 of the way through the surgery, and a friend of mine was doing my surgery. He said, "Yeah, you were coming out, and I could tell because you were pulling your leg away from me as I was." He said, "I looked over an anesthesiologist. It was a nurse anesthetist, and said, 'I think he's coming around.'" He said her response was, "Oh my gosh, hang on a second." And then I said, "I don't even remember any of that." He goes, "Yeah, that was by design." So I didn't remember a thing. That was great. Think about institutional core. What was missing in the 1800s? How was education for physicians and nursing during the 1800s? Was there education for them? It was spotty, wasn't it? You know, it was pretty crazy. You think about it. You know, you got your snake oil salesmen coming through town a few times a year, and you're hoping that that's something. You know, we were in. I think it was a couple of years ago. We were in New Mexico, and we stopped in, and there was a museum that had a collection of these tonics that they had been selling in the 1800s, and I looked at some of these, and they had listed on a card in front of them the contents of what was the strychnine. I mean, all these things that are heavy metal poisons that are in there. You're just thinking, oh my gosh, if you didn't die from your ailment, you're going to die from the treatment, right? So it's pretty interesting. What about demand? What type of economy and what type of settings did we have mainly in the 1800s?
More like a agriculture, farming type economy.
Yeah, agricultural, basic, a lot of rural settings, right? So what does that do for your demand if you're trying to create a center or a location to provide healthcare?
Makes it really hard.
We think it's hard enough now. We have transportation like cars and buses, and you know, if you really need to go somewhere and to get to a service, you can get it, and it's far away. You can get on an airplane. Most of this stuff was by wagon or by horse, mule team. I mean, supply was pretty spotty, right? So your physician wasn't his primary job was not to be the physician in most cases. Isn't that a little scary? And you think about how a lot of physicians received payment back then. You might come take care of your family, and then you pay them 3 or 4 chickens. You know, it's what you paid in, right? Whatever was available. That'd be kind of nice now. I would raise chickens all day long to take care of my health care if that's what it took, right? All right. And medical education as a whole was pretty unheard of, right? So you look at mid 1800s to 1900s, you know, American physicians started to receive more education. We started to understand a little bit more about how it all worked, right? And you started to see more centralized locations for populations, and so a physician could really have that as a primary job. Science and technology advancements. Think about, you know, I talked about hand washing, vaccinations. That alone is incredible. The idea that we can take a foreign body, isolate it, and then and inject that isolate into our systems to build our own immune system against something is pretty remarkable. Unheard of, you know, prior to, you know, 100, 150 years ago. The idea of exposure was pretty wild. So do we remember how the whole term vaccination came around? Anybody recall that? The word vaccination comes from the derivative of cow. And so I'm always bad with the country's name. but milkmaids were not getting, they worked around cows who had cowpox, and they found that those milkmaids were not susceptible to smallpox, or they would get a lessened severity of the contagion and survived. And so they found by being around that there must be something to that, and they looked into it and come to find out, sure enough, we can take this contagion and isolate it and give you a shot, give you some exposure, and build your immune system. And so the term vaccination came around. So it's pretty interesting. I mean, the way we discover things is almost miraculous. What about institutionalization? What did that do for our education with our physicians? You guys are the quietest group. What do you think?
It kind of gave it some authority, like legitimacy. in a way.
How so?
They created like a standard, I guess, a standard for educating physicians.
So standardization, right?
Standardization.
Let's talk a little bit about that. I'm going to show you a family tree, a little line of my family tree here. This is an interesting story. I only included it in here because I find it funny. So this is part of my family tree. It goes back through my mom's side. I have I think it's 5 generations ago. It's this guy right here, Edward Felix Knott. You can't really see it. It was a bad screenshot, but E.F. Knott was, I don't know, it's that 1, 2, 3, 4, 5, 6 generations ago. So however many grandfathers that is ago, he owned this place. This is the old medical college in Griffin, Georgia. Found this photo last year and thought I should at least give some credence to my story. What's that? Yeah, so I'm just making this up. Yeah, exactly. So it's on the old historical area. It's listed on a historical site. So however many great grandfathers ago, he owned this medical college, and basically it was pretty successful for a while. And my understanding of it is that it was successful, but they weren't, with a lot of the standardizations that were coming through, it ended up being not as successful as it could have been. They ended up losing it due to a lien because of an unpaid debt for some carpentry work. So otherwise, I probably would not be teaching at ETSU, right? Hopefully, I'd be maybe teaching there or something. That it's pretty remarkable, though. This is one of those institutional things that because standardization occurred, some locations couldn't keep up, and the education that was required was that was being given at those locations was not up to the standard that you would see in other locations. So it's pretty interesting. My family and I would have a good laugh about it. The building's still there. I always wondered why it was so large, and I found out that he had 11 kids, so that explained the buildings behind it. So nowadays, let's think about where we are versus back then. Think about patient dependency. Are our patients dependent upon knowledge of a physician, and why?
Yes, because we assume that they know what they're doing.
Yeah, and why do we assume that they know what they're doing?
Because they have medical knowledge like they from school.
Yeah, they've got all these degrees, right? And we assume that they studied hard. My uncle's a plastic surgeon. He says, Ryan, you know what you call a physician who made C's all the way through medical school. I said, no, what? He says, doctor. So, you know, we assume they're all highly educated. A lot of them were just mediocre students. I won't mention names, but there's some physicians that I know of that you think, man, if they can do it, why can't everybody else, right? But patients are highly dependent upon their knowledge, right? Their ability to diagnose and their ability to understand. They speak a totally different language. So, give you an idea, I came from, before I got into healthcare, I was in the nuclear industry, where I thought that the terminology involved in the nuclear industry was ridiculous. And I came into healthcare and I found out that the acronyms that I'd been using in that previous industry had nothing to do with the acronyms that are involved in healthcare. Healthcare is ridiculously over the top when it comes to their acronyms and the language that they speak. And to a patient and an outsider, these are all foreign. And I've been in the industry for I don't know how many years, and I will tell you, not a week goes by that I don't have to ask somebody, what does that mean? Because you know, these acronyms and these names and these new diagnoses are amazing. It's hard to understand everything. And so if you're on the outside, how does that make you dependent upon your physician? How much more does that make you dependent? Now, part of the problems with that you run into, going back to the increase in the corporatization of the medical field and the rise of all these managed care organizations, the autonomy of a physician, do you think that would diminish or increase the autonomy of a physician? Is that too wordy? How does all this big business affect a physician's ability to practice?
They have less autonomy.
Okay.
There's more rules.
More rules equals less autonomy, right? So someone's telling them what they have to do. Is that good or bad? Or both? Both, right? So tell me why it's good.
Standardization.
It's nice to know that when you walk into a hospital that a procedure is a procedure, isn't it? It's not the Wild West anymore. You don't walk into a hospital and this guy's going to try something new out on you that day without your consent, right? It's pretty good. Now, what's the negative side of that? There are a few, so. I love it when no one wants to answer. Seriously, I see people look straight down at the floor, the ceiling, the walls. This is great. What do you think? You look anywhere but here, right?
Yeah. Paperwork, maybe having to like go through a system to get care.
Yeah, so think of all of the forms that not only you have to fill out, but a physician has to fill out. How many of you have been to the doctor in the last year? Almost everybody has been to the doctor in the last year, right? Have you ever had the experience where the physician comes into the room and sits down in front of a laptop, and that's what they stare at 75% of the time? Okay, that's all, for the most part, regulatory compliance. They're trying to make sure that they're documenting what you're telling them, and then they refer back to that document later on. That makes it less personal, in my opinion. And sometimes I don't think they hear me. So that's a problem, right? Any other issues you can see with all this oversight? Always hear lack of incentive to develop new things, or to try new things. It does, to some extent, I think that can be true. But then again, do you really want someone trying new things on you? Yeah, that consent, right? All right. What has it done? How has organization increased, though? Talked a little bit around it, but think about your health records. prior to recent history, if your physician was in a rural setting, they just knew you and they knew your problems, right? There was no documentation of your health, no systematic approach to monitoring your health and seeing trends and following your health patterns. That's, in fact, just probably in the last 50 years that we started to really look at people on that type of paradigm, right? So it's pretty, the idea of bringing high reliability or consistent results and outcomes into an organization is fairly new idea. Malpractice insurance is there for a reason, right? Can you imagine if we were to be able to develop our procedures and our other areas of treatment to a point where there were very few, if not just zero, poor outcomes? It'd be amazing, wouldn't it? Think of surgical mishaps, leaving utensils in people's bodies. This is all really bad stuff, right? But more organization has led to our ability to monitor and to prevent these things from happening. So, for example, yesterday at our hospital was our monthly quality meeting, and we went over all of 2018's data. There's something like 426 metrics for the hospital. It's a lot of metrics. I like to call it job security, because that's my baby. And we looked at any outliers that we had during the year, areas that we had improved, areas that we need to change our metric to finally have a metric that's attainable. And it's really interesting to be able to see these things. I'll make a note to myself. I'll bring in a snapshot of one of those meetings for you sometime, just to give you a general idea of how healthcare systems, when they monitor these things, can make improvements. I'll give you an example of that. We had in 2017. Now let me give you some background before you freak out when you hear this number. Okay, so in a rehabilitation hospital, the expectation is for every patient to be fairly autonomous and be able to get up, move around. We want them mobile. That's the goal, is to get you home, have you be mobile. A lot of patients come in horrible shape. They're not moving, but they get a little confidence, right? And they begin to become more mobile. And so in 2017, we had 79 falls in the hospital, okay? Which put us at a 8.026 rate. Our goal was to stay below 8.0. So we stayed right above it. We just, literally one fall would have put us under our metric. It's pretty sad, right? And I think our last fall of 2017 happened on like Christmas Eve, if I remember correctly. And I just remember thinking, great, that was the one. So we did make our metric in 2017. So we made some adjustments, right? We developed an organizational plan. We looked at the organization as a whole, and we said, what can we do across the board? Not just with nursing or with our physicians, but what can we do across the board with therapy, environmental services, plant operations, food services? What is it that we can implement to make a change in this? So we changed all of our training for all of our employees on how we treat patients. And in 2018, we had 59 falls. So we reduced it by a full 20. That's almost less than 2 a month. That's pretty remarkable. And we came in at a 6.024. So over two 2 full points below. That's pretty incredible. The problem that I saw, though, is that in 2016 we had 55 falls, and we were at a 5.8 something rate. And then in 20, it's horrible, isn't it? And then in 2015 we were at a 9.23 rate. We ended up with like 80 something falls that year. So there's no consistency. So when we adjusted for 2018, we literally said, what did we do in 2016 that was so good that made things work, and what happened in 2017 that made us so bad? And we did a comparison, and we looked at the data, and we found some anomalies between the two. And we made some other changes, and it seemed to have helped. We had a really horrible month in November. We were well on our way to having a record-breaking year, and in November we had 10 falls. We had one patient who fell 5 times in our hospital. You know, when somebody falls once, I think, okay, it'll be fine. Patient falls a second time, I usually say, okay, guys, there's a problem here. Patient fell a second time. We need to be really vigilant. The third time this patient fell, I about lost my mind. And when I found out that it was the third, fourth, and fifth times that we literally had a sitter in the room with this patient and they fell. Now we're not talking fall like they're up walking, they fall. These were assisted to the ground falls, no injuries, things like that. In fact, in last year we had 46 falls with no injury at all. 13 falls that were minor in nature and 0 major injuries. So that's incredible. I'll be honest, that's an incredible number. When you have 13 falls in a year that have minor injuries, we're talking where they slid out of the bed and they scraped their arms, they have a little skin tear on their arm, but no send you back to the ED because you need to have an MRI, no broken bones, no lacerations, nothing major. So that's pretty incredible. So what we changed were signage, training, and vigilance and rounding. Okay, and we made that a focus, and it seems to have worked. Today's the 24th, is that right? 24th of January, and we've had only 2 falls this month. I may have just jinxed us and end up with one every day for the rest of the month. But that's how organization over time helps to fix problems and helps to improve an organization. The actual idea of organization. Okay. All right. Licensing. Can you imagine going to a physician who's unlicensed? If you had Dr. Chesley for ethics in your undergraduate program, if you were here for undergraduate, you may have had me come in and talk to you about physician credentialing and licensing. I do a whole thing on this Dr. Brown, who was an Army medic, and he stole a license after he was in prison from another physician. He only got caught because he started using the same pharmacy as the physician that he stole the license from. He practiced for years and years in the town that he was practicing in, said would not press charges. In fact, many townspeople went and spoke on his behalf because they said he was the best doctor they ever had. But he was an unlicensed physician. Can you imagine? So how many of you want to go have a colonoscopy from a doctor who's not licensed? I hope none of us in here want to have a colonoscopy, much less from one that's unlicensed, right? That's kind of important, right? Licensing. Why is licensing so important? What does it do? There's that S word again. What is it about licensing that makes us feel more comfortable?
You know that they're held to a standard.
That standardization, right? We know they met the minimum standard to pass a board exam. Makes you feel better, right? He's at least good enough, right? You go to your dentist, you know she's good enough, right? She's good enough. She passed a board. Okay? So what about this, that when did this happen? What is that part called? I'll tell you. It's the next to last bullet point. Education reform, right? We had education reform that said, hey, we are going to look at how all of our physicians in our country are trained, and they're all going to receive, if not same training, they're going to have similar training to meet specific items. So it's kind of like if you go to any medical school in the country, do you believe that those physicians are going to study anatomy? And what anatomy are they going to study, right? They're all going to have similar courses. It's if you want to become a psychiatrist, you will have specific things that you have to study in medical school to help you be a psychiatrist. You can't just go through your routine, become a anesthesiologist, and then last minute say, you know what, I think I'm just going to start practicing psychiatry now. Okay, you haven't met a minimum standard. You don't have a minimum standard of education in order to become a psychiatrist if you've been an anesthesiologist, and vice versa, right? All right, and speaking of those are considered specializations, right? So what has specialization done for us as a society?
It's giving us specialized care.
Specialized care. And having isn't it great when you can use the word and the thing? Specialized care, right? Think about specialized care. Most of our primary cares will refer you to a specialist. And why? Why do they refer you to a specialist for an ailment? They know more, right? They've studied that specifically. I'll give you my own personal example. So about 4 years ago, I noticed I started getting these scars on my face. Like I got a scar here, and I got this ugly guy like right there. And people would ask me what happened. I tell them I've been in a bar fight, and I've never even had a sip of alcohol my whole life, so that made it really funny, right? And people looked at it like, what? No, what is it? And then I had no idea. And my biggest fear was that I had some form of cancer. So I went to my general practice primary care physician who looked at it, and he says, that does make me nervous. Let me send you to a specialist. So he sends me over to this specialist, and they look at it, and the specialist says to me, you know what, I'm going to do a biopsy of those things, and I will send it off to have it looked at, but I am 90% sure that I know exactly what that is. And so he gets back with me and he says, yep, all my suspicions were correct. You have this really, really, really rare form, like 1 in 80 million people form of a linear scleroderma. You're not going to die from it, but it can turn into a full-blown autoimmune disease, so we're going to keep an eye on it. So, he said, good news is you're not going to die from it. Bad news is you're not going to get any prettier. And so I said, I can live with that, So I went home to my wife. I said, take a picture of this face because it's not going to look like this the rest of its life. And, a lot of relief came. And they've been treating me for the last few years, and it hasn't progressed anymore. So far, I'm not any uglier than I was a few years ago. So it's not bad. But it's because of a specialist. The funny thing about this was the doctor that I went to see, he called up a friend of his who he was in medical school with, who works at the Mayo Clinic, and says, hey, let me ask you a question. How many of these patients have you seen? I want some advice on this. And his friend said, in books or in person? He said, in person. He goes, I have never seen one in my entire career. And they've been practicing for over 20 years. He said, but I've seen them in textbooks. So that scared me a little bit because there's no cure, right? So anyway, but a specialist, he's continually doing research to see what there is to help me. Whereas if I go back to my primary care, do you think he is going to be able to help me any better? Of course not, right? So for example, are you going to go to your primary care and expect him to treat you for cancer? Or treat you for, I would not want my primary care physician to necessarily be the one that fixed my ankle, for example, when I had those problems. I'm just falling apart. That's what it sounds like, right? So I am. called middle age. All right, so we beat that one to death. Any questions on that? Any concerns at all? Still awake? Still with me? Still with me? All right. So community mental health. If we look at community mental health, think back, what does your imagination tell you if you think of community mental health 100 years ago? It's your imagination, it can't be wrong.
Like an asylum?
An asylum, right?
Terrible.
Yeah, it's horrible, isn't it? And it's a very good assessment of where we were. Your imagination is pretty much spot on. So the interesting thing about mental health in the community versus standard medical health in the community, which they both are medical health, but when you think of it, institutionalization was very high in the early 20th century. They did not understand mental health the way that we understand it now. We still don't understand it. It's one of the least, it's the lowest funded portion of our healthcare system. And so people who had, Down syndrome were institutionalized. I can't even speak English today. And they were institutionalized because people didn't understand them, didn't understand what was going on. Okay? And that's not a mental health issue. They were different. So think about nowadays. Think of the life expectancy for someone who had depression back then. They didn't understand. We still don't understand depression, right? But we understand it better than we did 100 years ago. My dad was talking to me about my grandfather, and he says, I really think your grandfather was depressed at one point. The whole idea behind it was just suck it up and deal with it. Now, there's major help for you if you have depression. And we understand that majority of the population will deal with depression at some point, and all of us will deal with it probably during our lifetimes. And it used to be any type of, think about the stigma that went with meeting with a counselor. It was considered horrible. Now it's turning a corner. Maybe I'm not necessarily broken if I need to see a counselor. They provide a service that helps me empower myself to get better in a lot of ways. Some things can only be treated by prescription drugs. Think of those who suffer from bipolar disorder. The understanding of how lithium works in the body, for example, for some patients who respond to lithium is remarkable. That's one of those last resort type drugs for that treatment, but it's remarkable. Think about the antidepressants that we are able to take now. It's amazing how much better off people are because we understand the human body better, right? But mental health was horrible back then. So we've reduced the total number of institutions and the total number of those who are institutionalized since. And we've increased our standard of care for all other aspects of mental health because of it. We have counselors, we have psychiatrists, we have clinical psychologists, we have a multitude of help available for the mental health area. As far as public health, really interesting thing about the United States is that our public health system is not well integrated into our health system. It handles outbreaks, they discuss social justices to try to make sure that people are taken care of with certain issues, but for the most part it's kept separate. This has pros and cons, but I think it's coming to become more integrated, and I think it'll continue to be more integrated as society changes. What about workers' compensation? So 1914 we get workers' comp. What happened there? What does workers' compensation do for you? Stand up.
If you get hurt on a job, they'll pay you, so.
Yeah, and you're not going to lose your job, right? Think about in the 1900s, you get hurt on the job, somebody's standing right behind you waiting to take your job, right? Think about what happened during the Depression. Anybody needed a job, so you broke your leg, you're out of luck. And your employer is liable for your health if you're injured on the job. So I'm standing on a ladder, and then the ladder falls and I break my arm. I'm not going to lose my job because I can no longer do the work that I needed to do on the ladder, and the employer is going to pay for me to get my arm fixed. It doesn't have to, it's not something that my insurance necessarily has to cover, right? So, health insurance in America. Let's think about blanket policies. This room is so small. It's really, I'm used to moving back and forth. I get claustrophobic. So, what's a blanket policy? This kind of covers everything, doesn't it? So, in 1911, we got our first blanket policies, and people would pay a fee, and it would cover everything that could be provided for at that time, right? So, by the way, just so you know, if I remember correctly, there are no dates really, except for when we get to like Social Security and Medicaid and Medicare. So don't worry about these dates. Okay, I hate dates. When you started work, if you're not already working in the healthcare field, you get into administration. Nobody's going to ask you, anything about the 1929 Baylor Plan, right? Who cares? I hate to say that, but who cares? That's why I don't like this chapter. And then I'm going to lose my job for saying that. I got 4 kids to feed. I got 2 kids in college, so. All right. So yeah, in 29, the Baylor Plan came out. And the Baylor Plan was basically, if you need to know anything about the Baylor Plan, this was the predecessor of the first Blue Cross plans, okay? And basically it was a prepaid hospital insurance plan to help school teachers. So in 33, the first Blue Cross plan came out. And I'm going to read this to you because I thought that this quote was pretty interesting. So basically what happened was, and I'll summarize some of it, that the American Hospital Association's Council on Community Relations, they decided that they were going to adopt a different approach and develop some kind of hospital insurance. So they looked at the Baylor Plan and they said, we can do something better, because what happens is a single hospital is not going to be able to provide all of the needs for all of these people. And we can broaden our base and provide cheaper health care, because the whole idea of insurance is we all pay in, but we don't all take out, right? So for example, we have a room of 10 people or 20 people and everybody pays $50. So you got 10 people. You got $500 going into a pool every month, which don't you wish it was that cheap? I don't know if you're paying your own insurance or not, but $50 a month would be great. So you're paying, but you have $500 in there, and then over a year time, you only have 1 or 2 claims, and those claims will probably be less than the total cumulative amount, and so you end up with a surplus to help pay for other catastrophic events. So insurance, that was what they thought they could do, and here's what they said. Let's see, it said it soon became obvious that a general community need could not be met through single hospital service plans. Let's see, the AHA sought to create insurance plans that were to be nonprofit, to emphasize the public welfare, and to limit themselves to dignified promotion. And then Rufus Rorum, who was leader of the AHA, said, pioneers in voluntary hospitalization movement were not philosophers. They were not social reformers. They were social organizers. The voluntary plans were an attempt to organize the public buying power on a voluntary basis without the disadvantage of political control. a means by which an employed group of people could finance medical care for itself. They were dealing with a practical problem in a practical way. So, unfortunately, with all of the things that we've had in the United States and throughout the world, the issue has become what do we do with all this money, right? And unfortunately, it's no longer looking at practical problems in practical ways, but we're looking at profit. The idea of non-profit organizations is that in my opinion, that's the most misunderstood phrase in the world, because they're all for profit. Okay? It's what they do with their profits that's different. Now, there are 501c3 organizations do have a lot of constraints on them, but they're not going broke. They're using that money in other ways. Most of their CEOs are doing just fine. Okay. My brother used to be CEO for Blood Assurance. You guys familiar with them? So they were one of the blood providers for Mountain States for a long time, and he did all right. You know, he retired at 55, so it's a good age to retire, in my opinion. Wish I could do that. I'll be working till I'm 78. That's a joke. So he'll be 76. Doing a little better than that. So, all right. So what happened in World War II? What was the problem? So they're trying to push health insurance, right? Trying to get a national health insurance plan. And in World War II, this was the big thing here, right? Socialized medicine. And it reared its head first time in World War I. They called it the Great Prussian Menace in World War I, socialized medicine, the Nazi plan. And so people still had bad taste in their mouth, right? World War II comes around, and it was just kind of a nail in the coffin for national health insurance. In 48, the National Health Assembly, they decided that they were going to endorse voluntary health insurance, but said that universal health care was necessary. So this is 1948, so we're talking, 70 years ago. But the American Medical Association launched a national campaign the same year, basically saying, we don't want national health insurance. Okay, and it shot all that down. In 54, Eisenhower proposed the Federal Reinsurance Fund. Okay, and that would allow private insurers to cover more people. And then the Revenue Act of 54 said that employers' contributions to employees' health plans did not have to be taxed. So that's an incentive for an employer and for the individual, right? So let's see. Yeah, we pretty much covered all this, but 1992. Any of you know what happened in 92? What the announcement was? So, what's up?
I was going to say Bill Clinton tried to get it passed.
Yeah, so President-elect Bill Clinton's there, and he's like, hey, we want a national health insurance. And he called it the, I forgot what he called it, like the Health Security Act or something like that. And he said, and I'm going to place Hillary in charge of this committee, and we're going to have national health insurance. And how well did that go over in the United States? Obviously, it didn't go over very well because we don't have it, right? And so what happens is you ended up with people saying, wait a second, how are we going to pay for this? And the answer is, how are you going to pay for it? Taxes. So let me ask the question, who in here wants to pay more taxes? I get that every time. Nobody wants to pay more taxes. Why don't we want to pay more taxes?
I guess it depends on what you get out of paying more taxes.
Yeah. So what are we going to get out of paying more taxes, right? And does the federal government have a really good track record for producing with our tax money? Look, I got two brothers in the FBI. I will tell you, the federal government wastes a lot of money. Okay. You know, there's no reason for a toilet seat to cost the federal government, $600. They pay these exorbitant amounts to their contracts. It's amazing, isn't it? How much money they spend. Do you know that only 49 states, I think Vermont's the only state that doesn't have a balanced budget thing in their state constitutions that says they have to have some sort of balanced budget, but the federal government has no requirement of a balanced budget. It's pretty scary. Do you have to have a balanced budget in your household? Can you overdraw your account without any repercussions? No, you can't, can you? I don't know. I was trying to find out if somebody had one that had a different bank than I had. Maybe it's working a little better for them. That'd be great, right? You can just print your own money and everything would be just fine. Federal government doesn't have that constraint, right? All right. Reasons that all these proposals failed. Number one, political inexpediency. So, see how we're doing on time. You guys are going to get out of here early today. I know that breaks your hearts, right? I can see the tears rolling. And this is my personal opinion, okay? So don't shoot the messenger, it's just my opinion. What's a politician's primary job? My personal opinion is their primary job is to get elected, all right? They're always running for office until they decide not to run for office anymore. That's all they do in our country now. Think about it. Someone gets elected, they go in office, and they immediately start planning their next election. Okay? So if the polls say that that the majority of your constituents disagree with you, do you think you're going to change your mind? Yeah, because it's your paycheck, right? So it's not expedient for a lot of these not expedient for a lot of these politicians to even make changes. Because it's just not there, right? They just don't have the votes. Now, when we think about the Affordable Care Act, everybody know how the Affordable Care Act was passed? I'm going to skip ahead because I think this fits in right with it. People forget about this little tidbit of information. All right, so the Affordable Care Act, how many votes did it have? Do you remember? Anybody remember how many it had? It had 51 votes. Okay, in order to pass a bill, you have to have 60 votes, okay? But they went back to an antiquated provision in order to be able to have a simple majority. Hadn't been done like that before, really. And they ran it through with 51 votes, okay? It's pretty interesting when you think about it. It's called budget reconciliation, I think. So they run a budget reconciliation on this Affordable Care Act, and it gets passed. And at the time of its passing, something like 52% or 53% of the country was against it, and with only like 30 something for it, and like 10 or 11% had no idea what was going on. So that's a situation where political inexpediency, despite that, there was changes that were made. So then fast forward a few years, and people get tired of that type of behavior, and what happens? I'm talking totally an uncomfortable subject right here. I totally get it, because a lot of people start thinking you're getting political. I'm not choosing sides, but you think about where we are now. Most people voted for Donald Trump not because of who Donald Trump was, but because of what he represented and what they were tired of, right? I think that's pretty common knowledge. I mean, the guy would stay off of his Twitter account, he probably would stay out of trouble, right? I mean, it's not what I would consider the presidential, right? So, but people were kicked out of office because of that, because of simple things they felt they were not being represented by. Okay, so trying to get in a United States of America where we are considered rebels, where we don't want taxation, where we don't want the federal government in our homes, trying to get something as huge as a national health insurance in place requires a lot of change. Okay. Think about the differences in institutions, right? Previous to the last few years, we've not had a lot of the standardization. And we continue to standardize, right? Just think about coding alone. Coding is a fairly new concept, and it's been revised and revised and revised. Our ideological differences go back to our political ideas. We have different ideas of what we think the role of government is. And again, we don't like taxes. Taxes, I'm telling you. All right. So before 1965, only private insurance was the big insurer, right? And then we had what we called the Social Security Amendments of '65. All right. So what are these two acts? Which is which? You guys know what these two are?
The first one's Medicare Part A.
Correct. Medicare Part A. So what does that make the second one?
Medicaid.
Medicaid, yep. Yeah, it allowed for states to provide health care. So here's the thing. If you look at the nature of the United States over years, the inception of the United States was that we were United States, okay? That we had individual states. We were not one mass government. It was individual states. And it started with each state having their own ideas about how they wanted their governments run. And over time, it's changed, correct? Federal governments become larger, state governments look to the federal government for a lot of their funding, and so the whole idea of Medicaid is really hard for people to wrap their heads around sometimes, because they think, well, why can't the federal government just force it? Well, they do. But there's still some autonomy within each state. So when they gave the option to expand Medicaid underneath the ACA, not every state adopted the expansions. So think about those states that did not adopt the new standards. So Tennessee was one of those states, right? And I believe there's still a gap in some coverage, right? And so it's made things in a lot of ways more difficult. But what is the primary reason that politicians are citing for not adopting? funding, right? Where's the money? And going back to political inexpediency, in a state that does not have an income tax, a lot of politicians saw that as a killer of their of their role as politicians and representatives. How are they going to get elected if you're the guy who decides to make Tennessee have an income tax to help pay for these things, right? So that's always been one of the items that stands out on that. So let's talk about Medicare. Part A hospital is hospital insurance, right? And Part B is the medical insurance. Okay, so what qualifies you for Medicare? And we'll talk about some of the differences between these two here in a second. But what qualifies you for Medicare?
Over 65.
Over 65 and qualify for Social Security, right? You had to have paid into the system. And that's for Part A, right? So there's no class distinction in Medicare. It's just age and being part of the system. There's no minimum dollar amount that you had to have made during your career, or maximum amount. There's none of that. So that saves, that's a guaranteed benefit, no matter what. Medicare also became in 1965 the biggest provider, single provider of health insurance, right? Biggest. Think about all those adults that are 65 and older now, and the size of that population, and the government providing insurance for all those people. That's a big group. It's a large group with large demographic, and so Medicare wields some power, right? In fact, when you look at regulations, my job at the hospital is compliance. So I look at regulations all the time, and Medicare is the one that dictates what we do. They set certain standards, then we have to meet them. We get our deemed status through the Joint Commission. That's our accrediting agency that takes care of that for us. So it has set national standards because of that, because they've become the largest payer source. So what does it mean that a physician could balance a bill? What is that idea? So if a doctor wanted, if there was something not paid, that's not covered in charges, so the charges a doctor had exceeded what will be reimbursed by Medicare, they could bill you for it. So that was how it was originally designed. But they had to be able to justify it. Couldn't just say, okay, well, this procedure is going to cost you a fortune. We're going to take your house and your car, even though Medicare just says that they're going to give us a motorcycle. It's all expensive, right? Let's talk about Part D coverage for a second. What is the development of Part D coverage done? It's easy to remember. It covers drugs, right? And it's helped out in a lot of ways, but still, even with Medicare coverage, it doesn't always cover every drug. All right. We really should just have an entire semester on Medicare. It's complicated, but if you can understand those basics, I think you'll be okay for right now. Okay.
And has any administration Democratic or Republican, been able to make much headway in changing Medicare? It's a huge cost. We've seen a lot of changes to reduce cost.
I don't think so.
Why? What is the reason it's such a big cost? Like the single insurer is because there's so many old people. And they are very good at advocacy and lobbying. They're a huge lobbyer. Do not, what is it? What was that thing? Don't put your government in my Medicare. Like they are a very powerful group of individuals. And so even both Republicans and Democrats have tried to reduce cost. And I mean, there are reducing costs in paying physicians less money sometimes, but not in reducing benefits or changing age limits. Like that is pretty much a non-starter.
Yeah. You'll never get reelected. You'll never get reelected.
There are too many baby boomers.
Yep. And it's a growing population. So
Yeah.
what do you do, right? I mean, it's there's all kinds of changes that could be made, but who wants? And it's funny because you watch both parties. Both parties go after each other. If one of them proposes a change, and the other party doesn't think it's going to help their cause, they'll automatically say, "Hey, they're trying to steal your benefits." They attack each other constantly
Yeah.
that way. It's like, seriously.
Yeah, it's very hard to make inroads with Medicare. Medicaid is a place where we're seeing some innovations or, changes to reduce costs. Some of them are maybe better in theory than in reality, but not Medicare.
Yeah. And I this is, like I said, this is my personal opinion, but I think a lot of that has to do with the fact that states run Medicaid and they have to have a balanced budget. 49 out of 50 states have a requirement on their constitutions that say you have to balance your budget. And so they look at it and they say, well, look, we've got to use some common sense. Remember that quote I read? You probably don't remember the quote because it all went in one ear and out the other, but the quote that I read was talking about the development of the Blue Cross plan in 1933. The whole reason was they wanted to put practical application in place to help people have coverage. And so the states look at it a lot differently than the federal government does. All right, so let's see, Medicaid, it's a state federal matching program, right? Federal government gives some money to help promote the idea behind it, and the states match federal government matches what the states will put in. That makes them have constraints on there. So not just say that you're 65 years old and you automatically qualify for Medicaid. They say you have to have income-based requirement, and it also opens it up to different age groups. The only problem with this is there can be class distinction, and with that goes there is a stigma behind that, right? People tend to have thought in the past that if you're on Medicaid, that it's because you're super poor, and people frown on you if you're poor, and those horrible poor people, right? Who can't afford anything. It's kind of a ridiculous idea, in my opinion, to have that thought, but we do, right? And so people will avoid it, which the end result most of the time is no coverage. And so think about the different states as well. Think about how it varies by state. The comparison between, even now it becomes more drastic as you have some states that have accepted the new guidelines and have expanded their Medicaid programs, and other states have not. Think about, for example, Oregon healthcare. I think in 2017 there was a report that came out, or an article, it's not a report, but it was an article that came out that talked about how Oregon's healthcare program was getting one step closer to complete coverage in the state of Oregon. But yet it was coming at an extreme cost. And you have the other sides of that is you have lots of people in those highly taxed states, like Oregon, New Jersey, New York. They've had problems with the total number of people who are exiting their states because of the high rates of taxation. So smaller tax base, still have high costs, not enough money to go around, so it makes it difficult. So deficits become a real problem, especially when you're in states where a balanced budget is required. Okay. Also with Medicaid, physicians may not balance their bill. It's not set up that way. If it costs a flat rate, it costs a flat rate. And for probably greatest example of this is in the skilled nursing arena, or long-term care arena rather, nursing homes. Most of your nursing home patients are Medicaid patients. Okay, so your resident in your nursing home is primarily a Medicaid patient. They put you on a program actually when you come in, because you can only have a certain dollar amount and still maintain your Medicaid. And so most Medicaid patients, even if they receive a retirement benefit, the business offices will keep an eye on their finances to make sure they never exceed the maximum amount so they can maintain that Medicaid benefit. The only problem with that is if I have a resident who requires higher level of care and their Medicaid benefit is a flat rate, which they are, you're only receiving a certain amount per day, then the problem becomes, how do I pay for that resident? It just comes out of your, lack of a better term, you're building a big pot of money and it just comes out of the pot. So you're building up a base from your Medicaid payers, and you are going to take from whatever you received in order to help cover it. So under Medicare, the rule is that you can have skilled nursing stay. You get 100 days of skilled nursing as your Medicare benefit, which allows you to have therapies and other functional activities that are not covered with Medicaid. But you only get 100 days every 60-day well period. And only 20 of those days of the 100 days is covered at 100% rate. The other 80 is covered with a copay. So it's not a completely free benefit. Medicare is by far not a free benefit. It's just in many ways like your standard insurances. Okay? But you have it. And so Medicaid won't cover things like therapy. And if you've exhausted your skilled benefit, you can sometimes do some therapies with your Part B plan, but for the most part, as an entity, as a provider, you just eat the cost. And so there's no balancing of a bill. There's no saying, well, this patient cost me this much and we're taking a loss. There are other provisions in place to help you out. For example, you can turn in a percentage of your bad debt at the end of the year in hopes that you'll get reimbursed a percentage, but that's a whole other story. But for the most part, Medicaid is not if you're looking at it from a provider standpoint, you're not going to pay all of your bills off of Medicaid, okay? So 3 main features of the corporate era. You think of big business, and it's exactly that. When you think of how this has changed medicine, in many ways, has gotten beyond the whole clinical aspect of providing care and wellness, and has gotten to big business, right? Talking about making profits. And so there's two arguments that I've heard about this. The one argument is the healthcare industry should be kept primarily to providing for the wellness of an individual. And then the other side is that the idea behind big corporations helps because of the large amounts of money that become available, and that can lead to greater levels of innovation because there are deeper resources. Are they both right? Are they both wrong? Or is it a combination of the both? I don't know. You know, you can see the pros and cons of both sides. But it's definitely something to think about as we further develop our into a system. What do we want to do? Do we want to truly look at this as a system providing wellness at all costs? And because of who is there? What are the ethical sides of this, right? At what point do you say you will not provide a service or something for someone? You know, we've had our ethics committee at the hospital. We've had this discussion a lot. You know, with, for example, patients who have spent a lifetime smoking. I think everyone's aware that smoking's bad for you, right? And so a lot of those patients who have chronic illnesses that are heavy smokers, the smoking has exacerbated the problems or caused the problems. And where as a society do you draw the line, for example, with that type of chosen behavior? Okay? So those types of things have to be discussed. Where do you want to place your controls? Where do you want to draw lines for treatment? Tell someone they can or cannot have a treatment. It's hard, isn't it? Those things are really hard. Information has become a key point of our lives. Think about your smartphones and what type of information is available to you just literally at your fingertips. Both good and bad, right? The worst thing that you can do is have a symptom and go online and try to become a physician yourself, right? And next thing you know, you think you have some chronic illness and you're never going to recover. Just to find out you have a head cold when you go see the doctor. So there's lots of things that can go with this information that we have. But has it helped more than it's hindered? I would say absolutely. Think about the advances that we've made, because now we've become this society where things are more transparent. You know, just think of the healthcare rating system that's now in place. While it's not perfect, it is nice to know that you can go online and find information regarding a physician, a hospital, and know what you're going to be getting yourself into before you go in there. It's a good thing. Any other thoughts on information? Any negatives you can think of that we haven't discussed? The wheels are turning, I can see it, right? Are you counting minutes till the class is over? Only got another hour. If it takes me an hour to go through 3 slides, we're in trouble. What about globalization? What effect has globalization had? The world is metaphorically smaller, right? It's become a very small world now. I mean, it's amazing that we can pick up a telephone, text message, send an email, send photos across the world, and just a matter of seconds have that information, if that long. I think about, okay, so for example, when I was living in Canary Islands, I would get, my family would mail me letters, and they'd send me packages, and I would mail them letters because I couldn't call home very often. It was a fortune to call home, and we only got to call home a couple times a year. So I would wait, and sometimes I wouldn't get mail for 3-4 weeks because of the way the mail system is. Now it's like, send an email to the people I know over there, make a phone call, no big deal. It's amazing. What has this done for the healthcare industry? Think about, for example, let's use teleradiology as an example. Now, you no longer have to have a radiologist in your hospital to read a film at 2 a.m. Okay, they can do a scan. The radiologist on a different time zone can look at that film, interpret what he sees, and send that information back with the results in real time. That's incredible. Think about things like claims processing. Okay, you can have your information here, right? And then someone in another country can process all of that information at a lower cost and save your organization lots of money. It's all because of the availability of information and because we've become this global community. Think about what's healthcare tourism like. Anyone know what that is? So you need a procedure done. I've asked my buddy Josh if I could use his example in class. So my friend Josh and I, Josh was diagnosed a few years ago with a really bad brain tumor. And some of the resources that are available in the United States that are not available in the United States are available in other countries because of the Food and Drug Administration's requirements they place on procedures and technology here in the U.S. And so Josh has been considering all different alternatives because here you got a fairly young guy, he's got small children, and he's dying. I mean, they have not put a time frame on how long he'll live now. And so he's looking at every resource he can. So health tourism is literally that, looking around the world for other opportunities. Now that's a really horrible example. I mean, it's a horrible situation. But there are other things. If people go for procedures to Mexico or have cosmetic surgery done in an Asian country, and we've seen all those horrible YouTube videos of how those things have turned out, right? But healthcare tourism is because of the globalization of healthcare. You can find that we can get, you remember all the talk about getting your prescription drugs cheaper in Canada, right? So people make purchases from Canada because there are programs where they can get that. Lots of little details like that, okay? But the world's become very small because of it. All right, really quickly, talk to you a little bit about the Oregon and Massachusetts plan. These were the predecessors for the Affordable Care Act, right? The big piece of this is that the Massachusetts plan was the one that had the individual mandate, and that's what helped us get to where we got a few years ago, right? So let's talk a little bit about the PPACA, okay?
You'll get to talk more about it in your case study.
Yay! Everybody excited? Look at them; they're just so
Yeah.
excited. All this.
And there's a section we added around Medicaid expansion to kind of delve into that as well, because this class, we always have to change things because healthcare doesn't stay the same. So you know, we've seen the PPACA, the long version,
Yeah.
the acronym, go through a lot of different kind of stages, and we've seen it try to get completely gutted. Why haven't we seen the true repeal of ACA?
It's hard to take away coverage once you've given it.
Yeah. Yeah. Tell all these young people, so we have the older people, that no longer can you stay on your parents' insurance until you're 26. That's something that almost universally everybody likes. There's other parts that people don't like. But yeah, you're right, Seth. Like, you can't just one day say, oh, you had this coverage. Oh, we had these really quality healthcare plans. We're just going to scrap that and go back to the way it used to be. Kind of hard to, what is it, put the toothpaste back in the tube after it's out.
Yeah, I can imagine telling somebody who has pre-existing condition, oh, by the way, now you're not covered after all. I mean, that's just rough, right? But there was a few problems that I encountered. For example, when I was in Arkansas, the company provided health care for all of our employees, but when this all passed, we found that it was cheaper to just pay the penalty for not providing health care insurance for our employees than it was to provide it, and then allow them to go and get their own health care. So no longer was that a benefit for our employees. That's what our corporate office mandated, and so all of those people lost their health care coverage. So that's pretty rough, right? You're on your own, and by the way, you're the lower paid group in the organization, so good luck. I hate to say it, I kept my insurance. They didn't drop my insurance. It's pretty sad, right? I don't think that was the best decision by our home office, but I didn't control that. But at the same time, from a financial standpoint, it made more sense to them. So, do we think that this debate's going to go on for the foreseeable future? It'll go on for years. I think the healthcare debate, regardless of whether it's the Affordable Care Act or whatever, it's always going to be debated in our country, and a lot of it has to do with the ethics behind things, people's different views of what the role of government is and the role of healthcare for our society. Problems with the ACA, the funding from day one, the funding was just not there, and part of it goes back to what we talked about with budget reconciliation, how it was passed. It was passed, like I said, passed with 51 votes, and so trying to get funding after that, virtually impossible. I imagine that there were lots of people making phone calls to their congressmen during that time period. Public support, we already talked a little bit about that. Some things it was phased in over time. That was one of the biggest complaints that a lot of people had, was that it would be phased in over time. And they questioned the constitutionality of that. Obviously that was upheld, but it was, as things were phased in, some people liked the items and some people did not. And so opinion has changed. In fact, if you look at the overall, I think you can go to Kaiser Foundation and look at the monitoring of public opinion on the Affordable Care Act, and you can kind of look at the dates when certain things are implemented, and within 2 to 3 months of that, you'll see how public opinion moves around with it. It's really interesting. Let's see. They did leave expansion for Medicaid up to each state. They validated the whole idea of individual mandate, and then it was removed by law, and it's been a mess. And then we've had, you think about the precedent that has been set in the last 20 years with executive actions. Things go back and forth. So funding, abilities of organizations to do certain actions halted or started just by a signature. So it's really interesting how politics has entered into your healthcare. And so I think that's just probably the best closing note you can have, is to think about society, what it is that's needed, what is public good and public need, and see how public need should be reflected through policy. Got any questions? Totally offended that I ran out of slides. Finished an hour early. All right. Anything you want to add, Dr. Beatty?
No, then your first homework is due on Sunday. Then your next homework and your first case will be due the following Sunday. The second homework, I think is really interesting because you get to choose from a couple of podcasts or a video that kind of delve into different interesting parts of the history of healthcare in the U.S. So there's a Typhoid Mary video, there's a podcast on contagion, there's one on the Spanish flu. So they give you kind of a peek into different really important things in the history of public health and healthcare in the U.S. And there's some kind of guiding questions that you answer after that. So I think it's pretty interesting. You can do the podcast while you're like driving in your car or, hanging out at your house.
Invite your friends.
Invite your friends.
Yeah.
I almost put one on there, and I'll just plug this as a really interesting podcast in general. It's called Science Versus. Does anybody listen to Science Versus? Do the kids even listen to podcasts these days? No. Okay. Science Versus is a really good podcast in that it tries to pit, a topic against the science around it. And so they have a 2-part series on vaccinations that was pretty interesting. Goes into history of vaccines and why people are scared of vaccines. Like vaccines nowadays are a lot safer than they used to be. You don't just cut your arm open and take the pus from another sick kid and put it in the wound of your kid and hope that the arm doesn't fall off. Like that's where vaccines came from. But the history of it. I was going to add that on, but you guys can listen to that. They have a really good 2-part series on the opioid epidemic. And then they have just like random things like the keto diet, like is it really a good thing? And, obesity, just interesting topics. But if you have any questions, let us know. And we'll see you next week.
Yep.